Dr. Green graduated from Rutgers College in 1997. Following that, he attended UMDNJ, New Jersey Medical School in Newark, and was inducted into the Alpha Omega Alpha Medical Honor Society. After graduating medical school in 2001, he continued training for 5 years at Monmouth Medical Center's orthopedic surgery residency program. He then spent a year in Pittsburgh training at the AGH Foot and Ankle Service, where he participated in all aspects of care of the foot and ankle. Dr. Green has a special interest in ankle arthritis and replacements. He is faculty and designer for several of the total ankle replacements on the market, and he is also very involved in consulting in the orthopedic foot and ankle industry, pioneering and utilizing the latest in orthopedic technology. So I'm going to have him put his camera on, and we're going to get started.
Good evening, everyone. Thank you, Savannah, for the wonderful intro. I'm actually impressed you did not crack up while I was doing what I do usually. Thank you, everyone, for tuning in at this kind of after work hour. I am one of the orthopedic foot and ankle guys here. I'm Ortho MD that has done a ton of ankle instability work and have developed some procedures and product for the use of this. So title of this is going to be the foot and ankle instability, and we're just going to get right into it. I think usually I say throw questions out as we go, but I think Savannah will kill me, so we're holding everything towards the end. You can turn your camera on if you want, and we'll go from there. How do I actually get the presentation to move? There we go. So ankle sprains and their reconstruction. So ankle sprains objectives. Grading, non-operative treatment, and then if non-operative treatment fails, ultimate operative management. Ankle sprains are probably one of the most common orthopedic injuries, and by far the most common orthopedic foot and ankle or lower extremity injury. 27,192 ankle sprains occur in the U.S. every day. That's an old number. That's from the late 80s from the American Academy of Orthopedic Foot and Ankle Surgeons. So we're probably a little bit higher than that, but still very, very common. It is an inversion injury. It's that injury you have when you step on an acorn or a rock and your ankle rolls inward and the outmost portion of your ankle just hurts. It will involve 3 of the ligaments of the ankle, the ATFL, which is the most commonly injured, the lateral collateral ligament, which is the second most common, and portions of the capsule, as well as the posterior ligament. If your ankle rolls all the way over, there may be some intra-articular or in the joint damage of cartilage and bone structures that will ultimately affect prognosis and recovery. From a recovery perspective, if you have a chronically unstable ankle, that can lead to post-traumatic arthritis. We have a great answer for ankle instability, but really a evolving but not great answer for ankle arthritis. The vast majority of ankle arthritis is post-traumatic, either from a fracture perspective or just people that have repetitively sprained their ankles in their 20s and 30s. This is a side view of the ankle looking at the outside. I'm not sure if you can see my cursor, but I actually hope you can because I just love saying cursor. You have 3 structures. You have the ATFL, or the anterior talar fibular ligament. This is the most common structure that's injured in an ankle sprain. As the ankle sprain becomes more significant, you have your calcaneofibular ligament. And then lastly, you have your posterior talofibular ligament, which is variably involved. But these are the 3 structures that are involved in an ankle instability event. Grading, you have essentially grade 1, 2, and 3. Grade 1 are normal ankle, you can see everything's intact. Grade 1 is a stretch of the ATFL. Grade 2 is a tear of the ATFL, stretch of the CFL. Grade 3 is a tear of both, just written out in text format. The involvement of the posterior structures are very, very variable. The posterior structures can impart a higher level of instability as well. A lot of times when you sprain your ankle and you go to the ER will say, oh, you have an avulsion fracture of your ankle. An avulsion fracture is actually where you tear a small piece of bone off of the distal fibula where either the ATFL or the CFL pulls a piece of the bone off the attachment off. They can charge higher or greater amount for a fracture than they can for a sprain. So that's why they tell you, oh, you have a fracture. These fractures or these avulsion fractures should really be treated as a sprain and will recover much faster than a true fracture. You can also have an avulsion fracture of the anterior process of the calcaneus. You may even see a lateral process of the talus fracture, but again, all of these are treated as sprains. On exam, your doctor, when you're in the room, is going to look at a couple of things. They're going to look at how much you can move your ankle, which is range of motion. They're also going to look at points of maximal tenderness. They're going to touch your bones, your medial mal, your lateral mal, to make sure you don't have a fracture. In Canada, which is a socialized system, they will actually not authorize an x-ray unless you have tenderness along a bone. Those are Ottawa rules, named after the wonderful city of Ottawa. Additionally, we're going to look at strength to make sure that your peroneals or the tendons on the outside of the ankle are functioning. Also going to look to see if those tendons are subluxing or moving more than they should. You can have bony pathology or cartilaginous pathology within the ankle. I'm going to look for talar dome pain or pain over the bone called the talus. We're going to do a draw test, which is where we're going to take your ankle through range of motion and stress it to see if we hear clicking. If we hear clicking, we know your ligament's torn and is not really functioning. Same thing, we're going to look at a talar tilt testing to see how much that bone called the talus actually moves. We can see that on exam and also radiographically. Initial treatment is always non-operatively. I personally would love to fix every ankle sprain operatively, but I don't have time in my schedule to fix 27,000 a day. So we really have found that the vast majority of sprains can be treated conservatively. About 1 to 2% will need to go on to be operatively treated. RICE or rest ice compression and elevation is your initial treatment. That will get the vast majority of grade 1 sprains better. Grade 1 sprains will recover pretty quickly. Supportive care, ice, brace, guided physical therapy. 2, where you're tearing one ligament and stretching the other, needs a little bit more immobilization. I generally put people in a walking boot. You kind of let them rest and then transfer them to a lace-up ASO. Then advance to therapy. Grade 3s are the more significant ones where everything is actually torn on the lateral side of the ankle. You can boot or cast these and then rapidly advance them after about 2 weeks. Historically, there's been a huge push for what's called McConnell taping. Very, very old school technique for stabilizing. We have found in multiple studies that any type of taping of the ankle is efficacious for about 10 minutes, and then all structural integrity of the taping is lost. So bracing is much more efficacious. And generally, I recommend all of my athletes who are trying to return to play go on to a formal bracing in a type of shoe or cleat scenario. From a supportive measure, non-steroidal anti-inflammatories are very, very helpful. They can be either topical or oral. And again, rapid mobilization has been shown to be very, very efficacious in return to physical therapy is really, truly essential. It's been one of the few things in the literature that's been shown to get an ankle sprain better the fastest. Early stages are focused on modalities like stim and ultrasound for inflammation control and massage for edema management. Once you get over the initial issues with the sprain, first week or so, then when symptoms start to subside, you want to look significantly at proprioception and stabilization. Proprioception is basically knowing or teaching your brain to know where the ankle is in space. So as the ankle starts to invert, the brain now knows to fire the peroneals and right the ankle. And peroneal strengthening is really just strengthening the tendons and muscles on the outside of the ankle. And this is, again, efficacious in probably 95+% of ankle sprains. I continue bracing RICE and other modalities for approximately 8 weeks. As long as symptoms are controlled and you're braced, I'm fine with you, anyone returning to play or full activity. The issue becomes at 6 to 8 weeks with still symptoms and on exam, and this is the most important part, where you're mechanically unstable, where the ankle still subluxes to anterior drawer, that there is other pathology that may be limiting your recovery and may need to be further addressed. Associated pathology that can hamper recovery is Peroneal tendon tears or dislocations. The peroneal brevis was the most likely tendon to tear at the level of the fibula. The other thing is during an inversion sprain, you may damage the bone of the talus. You may have a talar osteochondral fracture. You may also develop a bony or soft tissue impingement lesion anterolaterally. So if people are generally well treated for about 6 to 8 weeks and still not improving, an MRI is your next most reliable test. MRI is accurate and will only miss pathology about 16% of the time. One of the issues that really hampers people from recovering is a peroneal tendon tear. Those are the two tendons on the outside of the ankle behind the fibula. Very, very common that when the ankle sprains, those tendons come around the fibula and tear. The brevis will most likely tear and be the most common one to tear at the level of the retromalleolar groove or at the level of the ankle. The longest, which has a little bit more of a strength function, can tear further distally into the foot. Always test for strength of the peroneals and subluxation of the tendons and look for pathology. If untreated, these tendons can lead to persistent ankle pain, instability, and really substantial functional deficits. If you look, this is an MRI. Again, hope you can see my cursor. This is the peroneal brevis, that big, long, elongated mass. This is the longest right there. You can see there is a tear right there where the brevis is kind of sheathing the longest and wrapping around it. Concomitantly, this is the longest tear. This is the os perineum, which is a bone that acts as a pulley for the longest. You can see there's a fracture through it. That's pathognomonic or telling me that there is definitely a tear peroneal longus that will need to be fixed. Tendons are a relatively hypovascular structure, or a structure that has very, very little blood supply, so they have a very, very poor capacity to heal. If you have a symptomatic symptomatic tendon tear, or specifically a symptomatic peroneal tendon tear, they will generally need to be surgically reconstructed. If your tendon is torn less than 50% of the diameter of the tendon, that portion of the tendon can be resected. If it's greater than 50%, that tendon generally needs to be repaired. And if it's substantial, they may need to be tenodiced, which is the longest tied to the brevis to augment their function. And again, this is just augmentation. If greater than 50% of the tendons teared, you may need to do more. There are several products out on the market that will help with that. Artelon, which is a trade name for a synthetic, which is PLLA, is a scaffold that is able to reconstruct and utilize to help heal a torn peroneal tendon. Again, here you see surgical pictures. Anything that is not in black, i.e. color, is a Artelon device, FlexBand, where you can see it's used to augment and help heal a peroneal tendon. This is a biologic scaffold where normal tissue will be able to grow into and help. This is a repaired brevis with a Artelon on either side of it. This is a longus with a long stretch of graft helping to reconstruct it. And this is essentially what the FlexBand looks like. It will be reincorporated into normal tissue, dissolve and go away over a period of about 3 to 4 years, being replaced with completely normal tissue that is your own. Peroneal dislocation usually happens during the inversion event. This is where you tear the retinaculum, which is a piece of tissue that holds the peroneal tendons behind the fibula. There is a retromalleolar groove or a groove behind the fibula that holds these tendons in place. If you're flat or convex, that predisposes you to have a dislocation event. If the tendons are dislocated and chronically dislocated, they have a high propensity to rupture or tear if left untreated. People generally describe as feeling that they have something snapping or rolling across the front of their ankle. Very, very uncomfortable, and something that definitely does need to be fixed in the short term. And again, here you can see this is a tendon that is completely rolling around the front of the fibula right there. You can see just how prominent that tendon actually is. Here you can see grading of it. You can see one of the brevis around. Here you see brevis around, the longest coming around, and here you can see actually a fracture where both the longest and the brevis of the peroneal tendons are coming all the way through. So grade 3 sprain dislocation of the peroneal tendons, and that actually needs to be reconstructed. Otherwise, these tendons get trapped and will ultimately get torn and really need to be reconstructed in a much more significant way than a primary repair. Here you can see this is the tibia, this is the fibula, this is the peroneus brevis, this is the peroneus longus. They are supposed to be sitting here. This is the retinaculum that we talked about that's supposed to hold them behind here. This is a relatively flat to convex groove. These tendons just came all the way around. You can see they're sitting lateral to the fibula. Actually just did a case yesterday relocating these. These need to come behind. What you need to do is you actually need to cut the bone here, groove deep in this, and then have the peroneal tendon sit in a groove, which is concave, which is supposed to look like that behind the fibula, and have them stay in place with a repair of the retinaculum, which is this arrow represented by the black arrow. And again, here you can see just another description of grade 1 through 3 peroneal dislocation. Dislocation treatment is surgical. Again, most will require fibular osteotomy, and you also need to reconstruct the retinaculum. Osteochondral injuries can also occur as the ankle sprains in an inverse type sprain. The talus will touch the tibia. That can result in a contusion, which will ultimately result in a clotting that can then impair blood flow to the bone and cause some bone death at the level of the talus. There are some different theories on how these occur. Some of them are congenital, some of them are traumatic. An instability event can again cause kind of bone bruise that will lead to an OCT lesion. Again, for me, unless they're a stage 4 lesion, which we'll show in a minute, I try to really treat them non-operatively, as well as non-operatively treating the sprain. But in reality, in an unstable ankle, they can and are an unstable and pre-arthritic lesion. Here you can see just a plain radiograph where you can see this is the normal talar contour. You can see this lesion with this little bit of lucency with a little bit of a spike of bone there, and that is a medial-sided traumatic talar osteochondral defect. This is an MRI depiction. Normal bone is supposed to be this dark gray-black color. You can see this whiteness with this inflammation. So you have bone marrow edema here, right around the lesion, and then just this little white spot, which is a true talar osteochondral defect. But you can also see that little black line of cartilage, which is the cartilage intact. So that's actually a good prognostic sign or a good indicator. Classification is Burns and Hardy. 1 is just bone bruise inflammation. 2 is that true osteochondral defect with intact cartilage. 3 is the osteochondral defect separated but intact cartilage on top. 4 is a completely separated lesion that will need to be surgically treated because you have a free floating loose body. Again, this is just in text format what the Burns and Hardy classification actually is. Treatment, most will become asymptomatic over time. If initial symptoms persist in a stable ankle, a cortisone injection can calm the inflammation and really make you feel substantially better. Unfortunately, if conservative management fails, operative management is required. Antegrade or retrograde drilling is generally the standard of care. 80% of those lesions will heal, 20% won't. Of that 20%, if they don't heal, grafting procedures can be done, either of synthetic or juvenile cartilage can be used. I always find it very, very important to evaluate for concomitant instability because I find OCD lesions with instability are symptomatic. OCD lesions without instability generally tend to be quiescent. So I always look very, very heavily at that. And if any type of surgical management is required, I will look heavily at repairing stability of the lateral ligament complex and getting a stable ankle. So here you can see arthroscopically an OCD lesion. You can see that ridge of tissue. Here you can see that tissue debrided with just frank eburnated bone. So cartilage around the perimeter, but exposed bone. The initial treatment of that is antegrade drilling. See all these drill holes that will still be like marrow to get everything to heal. If you have a lesion where your cartilage is actually intact, you can do a technique which was developed by myself where I did my fellowship in Pittsburgh called retrograde drilling. Here you can see on the MRI, you have an OCD lesion represented on a T1 sequence. With that black lesion, you go in from the lateral side of the talus and drill it and decompress it. And that works well, keeping your articular cartilage intact. Or you can ultimately graft it. This is with juvenile articular cartilage harvested from donors who are less than 12 years old. You have your lesion here, you clean it out, you then do a dry arthroscopy, implant your graft, and then glue over it. I've had huge success with that. It really heals as absolutely normal cartilage and works very, very well. In my world, there are sprains that get better and sprains that don't. Sprains that don't get better, you have to really look at if they are if they are stable on drawer testing or mechanically stable, and are weak. That's functional instability. If they're just lax, that means they're mechanically unstable. Again, if functionally or mechanically stable, consider cortisone injection with continued bracing. Future technology, which is actually shown to be very, very beneficial in inflammatory conditions like sprains, amniotic allograft, which is basically donor stem cells from the placenta. They have a huge amount of growth factors and anti-inflammatory properties and will really help decrease the inflammation in the joint. PRP, which is platelet-rich plasma, is or autograft blood. You harvest it from yourself, spin it down, and that has all the growth factors and has also been shown to have some stem cell capability as well as huge amounts of anti-inflammatory properties. Lastly, there's just formal stem cells where you harvest from either the iliac crest or from fat stem cells from the abdomen. They will regenerate normal cells. All these are new and emerging technologies that work very, very well. However, generally considered experimental and not considered by or covered by insurance, but are efficacious and do lead to healing. From a mechanical perspective, if you're really still unstable, your options are to be continually braced or surgical reconstruction. Historically, there were two types of reconstruction, anatomic and non-anatomic. Non-anatomic reconstruction utilizes a tendon graft, high likelihood of developing post-traumatic arthritis from non-normal movement or kinematics. Anatomic reconstructions using an either autoline flex band or other synthetic reconstructions are very, very efficacious and have low risk of recurrent instability and do very, very well in the future. Again, from a surgical perspective, we always do a modified Brostrom-Gould reconstruction, which is reconstructing your ligament. Secondary repairs, again, like your autoline, can help with preventing a resprain in the future. If there's any type of pain in the ankle, I always recommend scoping the ankle or doing an arthrotrope minimally invasively to look for any intra-articular pathology that an MRI will miss, which is approximately 60%, 16% of cases. Here is a Brostrom-Gould. This is your ankle joint. This is the ligament. This is the ligament. You sew these two pieces together and they heal very, very nicely. Again, primary repair, ligament, suture. This is a secondary repair where you're throwing suture anchor with fiber tape into the talus. You will loop that into the fibula, and that will be your secondary repair. That is tied looser than your primary repair. So if you sprain your primary repair, your secondary repair is still intact to hold, so you will not be unstable. Again, a secondary repair with anchors, one anchor into the talus, one to the fibula, holding tension of what would be your normal anterior talofibular ligament, which is reconstructed. This is the flex band, which is an Artelon product which really very nicely functions as a resorbable secondary repair, which will become part of your normal native tissue and go away with time. Overall concept is your primary repair is done in fully version to hold. Your secondary repair is in neutral to really stabilize in case you do sprain again. If utilizing this technique with a secondary repair, you can really rehab much, much quicker. Historically, I would always keep these patients in a cast for 4 weeks. Right now, I keep them in a brace for about a week to 10 days, and then mobilize them in a walking boot. And as long as braced, I have no restrictions at activity, approximately 10 days. As technology improves, new procedures will be developed by people like myself that allow for better and more rapid healing and outcomes. Thank you.